good evening, good afternoon. Today we're going to talk about vitamin K2. It's got a role in terms of cardiovascular health. People have talked about K2 and their focus on, does K2 actually get calcium out of the arteries? But recently, in fact, just last week, Daniel Trevor, one of our viewers, and a fellow who's working on a book, it covers a lot of our content. I mentioned him and his book a couple of weeks ago. He and I were talking about this, and he raised the issue of vitamin K2 for osteoporosis. One of the things that really intrigued me was the dose level of K2 used for osteoporosis. You remember in the cardiovascular area, if you get vitamin K2, you'll usually see 100 micrograms, 200 micrograms, something like that. One of the things that I discovered as I was going through the science on K2 was that it has an impact on diabetes, insulin resistance. We'll talk about that a little bit later. But the studies that I saw were up around 300 and 400 micrograms. They actually did clinical trials where they showed decrease in prediabetes and diabetes among young and middle-aged men, but they were using 400 micrograms. The amounts used in these osteoporosis studies were 45 milligrams. We're talking 100 to 150 times the dosage used in cardiovascular health. And so, those of you who've been worried about, well, is 300 or 400 micrograms too much? I don't think so. We're going to talk about this today, get a little bit deeper into vitamin K2, talk about the osteo side, osteoporosis. We don't cover usually a lot of osteoporosis on this channel. So this will be a little bit of a venture for us. And then we'll go back and talk a little bit about vitamin K2 and cardiovascular health. Other things that we've covered, the fact that the pandemic is more of a blood glucose problem, maybe, than anything else. And we'll have another slide as a reminder on that today. How to prevent strokes, vitamin D, interferon beta, and several other things. If you'd like to get our information, one of the things that the science has shown is that unfortunately, most primary care doctors don't know how to diagnose prediabetes or diabetes that well, let alone how to manage it. And, there just aren't enough docs out there that know how to manage it. So one thing you can do is continue to see your doc, but come in and get a little bit more information regarding key things that will drive your health. Things most likely cause of death and your most likely cause of disability. Heart attacks and strokes, again, 80% driven by not LDL, but LDL is a risk factor. So a lot of people don't believe that. It is, but it's nothing compared to prediabetes and diabetes. So the way to come in and learn about this is just, first of all, you got to acknowledge this is a harsh reality in our world. Medicine is like some things, some marketplaces, buyer beware. Don't assume your doc knows everything she or he should know about the things that are really going to kill or disable you. The science is pretty clear they don't. But you can learn it. It's not that difficult. We've got 3 courses here. One is on plaque evaluation. The best way to evaluate your plaque is not using a Framingham and then a stress test and then go to the cath lab. Those are great ways to get a stent put in that you probably won't need. There are other ways. There are better ways to evaluate your plaque. You can learn about it in the course. These are the courses. They're video based. They have text as well, and we're actually doing a lot of work. They've become very popular, and we've got some employers who are starting to take a look. We're getting, I've always been notorious for having shaky paper in front of a webcam, and we're improving our act a little bit. Because of, again, thanks to you, the folks that are showing interest in this. A lot of folks have shown interest and have said, you know what, you're expensive, and I am to see, but sometimes it's easier on a subscription type of basis. The book, I grimace every time I bring the book up. We are getting closer. It's a deep, deep dive into what I just mentioned earlier, plaque, and what a stress test can't tell you. So check out the website. Now, I mentioned a minute ago, this pandemic, gosh, few things have gotten more political the past year than COVID-19. It's interesting to note that virus knows which way you vote. However, I'm not going to go there. Where I am going to go, though, is to repeat a slide that we've done a couple of weeks ago. It was a presentation by at the Endocrine Society Conference of 2021. It was of admissions to a COVID hospital center in New York City. And what they found was high glucose was a bigger risk than prediabetes or diabetes. Now, what does that mean? What that means is the 90% of people that have prediabetes or diabetes and don't know it are at much greater risk for their health. And we've known that from day one. Once you get this diagnosis, it's not easy to get started and change your lifestyle and get where you need to be, but it's a heck of a lot easier than becoming paralyzed. So they looked at, and again, it's happening again it happened with heart attacks, it happens with strokes, and now it's happened with COVID, coronavirus infection. If your glucose was over 140, you had greater risk of full-blown COVID and bad disease, whether you had a history of diabetes or not, whether it had ever been diagnosed. 2.4 times greater odds of intubation, 2.4 times greater odds of going into the ICU, and a much greater risk of having kidney injury. If your glucose was 180 or more, you were much more likely to die, whether that you had a history, a known diagnosis of diabetes or not. 4 times greater risk of death, almost 3 times greater risk of intubation, and 3 times greater risk of going to the ICU. Now, again, you could say, is this a chicken or the egg question? You're not going to have these high glucose numbers unless you have a problem. Again, get the problem diagnosed. That's the message. And then once you diagnose it, you can manage it. So, to our program for today, osteoporosis and vitamin K2. Osteoporosis is prevalent with aging. There are, and as most of us know, it's a much bigger issue with women than it is with men, 3 to 4 times more likely with women. There are 25 million people in the U.S. with diagnosed osteoporosis right now. There are more than 2 million fractures per year in the U.S. attributed to osteoporosis. One of the major risk factors is blood thinners, especially the ones that are called vitamin K antagonists. And we'll get some clues on why that's the case in just a few slides. Now, how about the NOACs? Xarelto, Eliquis, not an issue there. They are the non-vitamin K antagonists, blood thinners. Those are the things that I recommend that you consider, for example, if you have atrial fib. Atrial fib, like prediabetes, like osteoporosis, like diabetes, is one of those things that the vast majority of people that have atrial fib don't know it. If you've ever noticed your heart doing this, and if you've noticed it more than once or twice per year, you're very likely, especially if you're age 50 or above, you're very likely to have paroxysmal atrial fibrillation. So, as you hear us talk about the vitamin K antagonists and osteoporosis, the issue starts to come up of which vitamin K are we talking about? There's actually vitamin K1 and vitamin K2, and there may be some others, but we're going to focus on those two. We're going to focus on an article called Regulation of Bone Remodeling by Vitamin K2. You see, the issue is bone is constantly being remodeled. Well, if you're remodeling a house, what's the first thing you have to do? You have to take out everything that's in it. So, and then after you take stuff out, then you put the other stuff back in. Well, that's where we get into the issue of Med Student 101, osteoclasts and osteoblasts. Remember, clast has a C in it and it's cutting. What osteoclasts are these cells that go in and they take out bone matrix, as you see here in this picture. Osteoblasts, on the other hand, are the guys that come back in the remodeling and put down new bone. So what does that got to do with vitamin K2? Hang on, we'll get there in just a minute. So the study that we talked about, we mentioned a minute ago, regulation of bone remodeling by vitamin K2, was what we call a meta-analysis. In other words, they looked at multiple different intervention studies. The dosage that they looked at was, as I said, 45 milligrams of vitamin K2 per day. They saw that as the minimum effective dose to prevent osteoporosis. Let me just go off script for a second. I don't plan to talk a lot about bisphosphonates today. I expect some questions to come up on it. I don't use them very often, although I do recommend them when they're needed. I expect we'll get some back and forth about those. So anyhow, they looked in this study at a meta-analysis of vitamin K2, and they did see some significant decrease in osteoporosis associated with 45 milligrams or more. Now, as we mentioned earlier, the folks that are talking about vitamin K2 for prevention of cardiovascular disease are talking about 250 to 300 micrograms. 45 milligrams is 150 to 180 times higher. So those of you that are worried about taking 400 micrograms, I doubt that's going to be a problem. No toxic effects were noted. So the results of these studies show that vitamin K has the potential to suppress bone resorption or turnover by inhibiting osteoclast-induced bone resorption and increasing osteoblast activity. So you remember we went into that issue of cutting down the bone like you're cleaning out a house and then putting stuff back in, and the osteoclasts cutting it out and the osteoblasts putting it back in. Well, vitamin K2 decreases osteoclast activity and increases osteoblast activity. And when you think about it, obviously osteoporosis in and of itself is an imbalance in osteoblast and osteoclast activity. Now, back to the script and mentioning bisphosphonates. Combining the vitamin K2 with vitamin D3 or bisphosphonates showed an additional protective effect. Now, anytime we start going into medications or supplements, you got to go back and remember lifestyle is king. It always is king. It's, for example, with prediabetes and diabetes, they've done trials showing that the most popular medication, metformin, which is a good medication, I use it a lot, but there's no question, just doing some of the right things in terms of lifestyle is 3 times more powerful than taking a medication. Well, does the same thing exist here? Yep, it does. One of the biggest things is resistance training. And when we get into our mid-60s, one of the biggest issues that we have is loss of muscle mass. That loss of muscle mass is associated with not only osteoporosis, like we're talking about today, but one of the biggest risks for loss of muscle mass has to do with cardiovascular inflammation, prediabetes, heart attack, stroke, and death. I mean, we're continuing to go through these same topics. Now, so one of the more common lifestyle issues that I talk about is resistance training. And when I go there, most people start saying, well, especially the men start thinking about upper extremity stuff, like you see Arnold doing over here. Upper extremity is okay. But it's really more cosmetic than anything else. We're looking for muscle mass. You see, muscles that are flexing and active actually bypass aging insulin receptors. So what we're looking for is muscle mass. It's the same thing in osteoporosis. Lower extremities are much more important to health than the uppers. I'm not at all against doing upper extremity work. The bottom line, though, is for health reasons, lower extremity work is king. Now, somebody asked me recently about resistance training, and they said, do we need to be constantly increasing our resistance and our reps? No, the goal here is not so much to, unless your goal is to start looking like Arnold, and there's very few of us that can practically expect that, even if we wanted to at age 60. That's not the goal here. Again, the goal is to decrease insulin resistance, bypass those aging insulin receptors, and in terms of the discussion today, improve our bone health. So I'm a little bit more concerned, well, actually not a little bit, I am a lot more concerned about the next item than I am increasing weight. Reps. Arnold has been quoted many times saying, reps, reps, reps. I'm sick of doing reps. And yet he's still doing them. What, pushing 70, maybe over that now? He's still doing reps, reps, reps. And so in the old days, people used to talk about doing, for upper extremity work, doing 3 sets of 8 apiece. And for lower extremities, 3 sets of 12 reps. That's at most 36 reps. I'm talking about 3 times that amount. And I've done videos on this issue because, again, this is such an important issue. There's no way you can do 90 to 100 reps at maximum capacity. Now, I'm not saying don't ever push your amount. I think it's very important to push your resistance, but only in the last 10. The first 30 should be embarrassingly light. The second 30, you should feel it. And by that point, you should also have a little bit of fatigue setting in because your muscles have been working for a while. And then that last 30, it's helpful to be hurting. But again, the bottom line is, it depends on your goal. If your goal is health, you don't need to try to look like Arnold. Speaking of resistance training, now there's a thing that gets I'm wearing a weight vest today. I've been wearing weight vests off and on for about 20 years. They get a lot of bad rep because some people try to run in them, which is really dumb. But this kind of, this is a 35-pound weight vest. I also use weight belts. And you may not have noticed it in the beginning of the video. Sometimes I'm using them when I'm doing videos. So it's a total of 50 pounds. That extra 50 pounds makes a big difference in terms of stressing your bones. So enough about lifestyle for osteo. Let's go back and talk about the history of vitamin K2. Most of the information about K2 focuses on arterial disease and calcium. Again, maybe less informed. The assumption is that K2 moves calcium from the arteries into the bone, a process that affects arterial plaque. You know, it comes from this whole thing of, oh, you had a positive calcium score. Calcium scores are very important. It's one of the 3 ways that I recommend evaluating plaque, but that's a whole different issue for a whole different time. I don't really think that the benefit from vitamin K2 comes from moving calcium out of your arteries and into your plaque. We'll touch on that. But first, a little bit of background. In 1935, the Danish biochemist Carl Peter Heinrich Dahm described a food additive that reduced bleeding in chicks that had been fed with an extremely low-fat diet. He named it vitamin K because the German word for coagulation or clotting is coagulation with a K. A few years later, the American biochemist Edward Adalbert Doisy determined that vitamin K's chemical structure, and then he succeeded in synthesizing it. Dahm and Doisy shared a 1943 Nobel Prize for their work on vitamin K. Now, as I've mentioned a few minutes ago, there's more than one version of vitamin K. There's K1, which is phylloquinone. That was discovered by Dahm and Doisy. Then there's K2, which is menaquinone. But then menaquinone has multiple different versions, like menaquinone 4, menaquinone 7. Those are the most common, but there's reasons that they're numbered 4 and 7. 1 through 3 exists, and so do 5 and 6. Now, simply adding calcium to your diet doesn't ensure bone growth. Other factors are involved, like hormones, vitamins, and as we just got through talking about, stress. Stress through resistance training, carrying weights, things like that. So when talking about calcium absorption, we first think of vitamin D3, but K2 may play a bigger factor, or at least a big factor. How? Again, as we mentioned in the earlier discussion with osteoporosis, osteoblasts and osteoclasts, the cells that build bone matrix and the cells that take it away. Now, osteoblasts produce a thing called osteocalcin. Osteocalcin is a protein with important roles in bone mineralization and calcium homeostasis. Osteocalcin is activated through a reaction called carboxylation. Carboxylation is dependent on vitamin K2. Now, where are all these bunny holes going? They're going back to the point that carboxylation and activation through of osteocalcin is very much related to prediabetes or insulin resistance. Now, K2 also inhibits osteoclasts. Osteoclasts are cells which we talked about. K2 also activates MGP, matrix GLA protein. It's another protein that helps to ensure that calcium is used in bones and not deposited in arteries and other tissue. Now, one final item, and I think that's going to be it for today. Dr. Jolene Boylan's work. Dr. Boylan is a professor of lifestyle and cardiometabolic disease epidemiology in Amsterdam, at the Amsterdam Public Health Program. Her research has focused on nutrition, cardiovascular health, and prediabetes. She's been involved in several studies that demonstrate K2, menaquinone, has a preventive effect on prediabetes. And over on the right, you see this article. She was lead author, dietary phylloquinone and menaquinones, intake and risks for type 2 diabetes. Not going to cover this today. The bottom line on it is K2 has been found in more than one place to decrease inflammation, cardiovascular inflammation, and again, probably associated with its impact on prediabetes. We've got a lot of content out there about K2. Got a lot of Q&A content as well as pre-videoed, pre-filmed content. That's another one on sources of K2. You know, K1, the sources are dark green vegetables. K2, however, is something very, very different. You remember that first discovery that chicks that were fed an extremely low-fat diet had coagulation problems. He fixed it with vitamin K. There was also an association with K2 in there, and that's where that's coming from. So what we'll do next is go into some Q&A. Gilbert, if you will give us the water ball. So thank you. We've got a lot of folks here, a lot of comments. John Tucha, good morning. James West. James didn't join us today. He did say that he got his best shirt on to show it off for the video, as he often does. But he's working, he is eyeball deep in terms of getting us prepped and ready for our Medicare Advantage preventive medicine programs in Alabama. Robert Weist, good morning from the North Georgia mountains. Good morning, Robert. Oh, brothers, can't talk about K2 without discussing calcium and D3. You bet. But we did. Bart Robinson, good morning. Could you please comment on Ivor Cummings stating you must take thanks, guys. Stating you must take vitamin K2 several hours away from magnesium. I've been taking them together for convenience. Bart, that's news to me. I did not know that. I'm not going to be qualified to comment on that. I have been taking mine together as well. Bambi Grage, good morning. Good morning, Bambi. How are you? Mary with us, with thee. Good morning from Texas. Good morning, Mary. Oh, brothers, morning. Haley Wright. I must have missed the segment on if K2 removes calcium from the arteries. What is your opinion? Studies. Here's the thing. Again, everybody gets so focused on calcium in the arteries. I will tell you, I've seen 3 patients over the past week who went through this same transition. You know, again, a coronary calcium score is very important. It's one of the better studies. But there is no really good study for heart attack and stroke risk. Clearly not stress tests. I mean, that's what Tim Russert had a few weeks before he died from his heart attack, and he passed it in flying colors. And there's a good reason for that. Look it up at the Princeton Longevity Institute and Harvard and several other places. We all know that 2/3 of heart attacks occur in people that don't have enough plaque to change the blood flow. And if you don't have enough plaque to change the blood flow, you're not going to have a change on your stress tests. So then people will say, well, you know, I know that having a positive calcium score puts me at risk. The higher the calcium number, the higher the risk. That's true. But next, you start to get into the misperceptions associated with calcium score. Calcium is not the same as soft plaque. In fact, a calcium score does not show soft plaque. There is a good correlation. The higher your calcium, usually the more risk you have. However, There is a very significant exception to this rule. I've seen it 3 times this week. It's not rare. It happens all the time, especially as you start taking control of your health. Here's the classic scenario. Somebody, they're overweight. They know they're running some risk, but it is what it is. I'll deal with it next year. Their brother has a heart attack, and that's one of the cases this week. So they say, dang, my brother had a heart attack. I really got to get that. I know I've got 20, 30 pounds I need to lose. He went on a keto diet. Oh, he did get a calcium score, by the way. The calcium score was 600. He went on a keto diet. He lost not only the 20 pounds, but 15 more. He lost like 35 pounds. Then he did another calcium score. Anybody want to guess what his next calcium score was? The first one was 600, lost 35 pounds. It went up to 1,400. Now, does anybody want to think that losing 35 pounds put this individual at greater risk for heart attack and stroke? No. And that's only one of 3 patients that I've seen this week alone with a very, very similar story. So don't get too wrapped up in the concern that, quote, calcium is bad. No, calcium is not bad. The more calcium you have, it indicates the more times you've been through this inflammatory process. And as we age, very few of us escape ever creating any calcium in our arteries. It's just harder and harder. The older we get, the more and more resistant our insulin receptors become to insulin. So don't get too wrapped up in that calcium score. Remember that health is not exactly the same as calcium. I hope that answered your question. I do think that K2 has a positive impact on health. I do think that calcium is not really part of the issue. I think, as I mentioned during the program, K2 has an impact on our insulin resistance, as we talked about with osteocalcin and matrix glyprotein, those things that are related to both insulin resistance and calcium deposition. Now, here's another thing. This individual that I talked about wanted to make sure that he got rid of that 1,400 of calcium, and he wanted some coaching from me. And I'm not going to make stuff up because I don't want people to get disappointed again. We need to come to grips with the reality that very few of us actually reverse calcium. We don't tend to get rid of it. Some of us have. John Lorscheider did. He had a huge decrease in calcium. Jerry Kurth did as well. John had like 60% decrease. Jerry had like 15%. Those guys are rare. They're unusual. You can get some decrease in calcium in your arteries, but that's not the goal. It's okay. It's okay if we don't decrease calcium. What we do want to do is get rid of our soft plaque. That's a very practical goal. All of us can do it. And guess what? I've got, vast majority of my folks getting rid of soft plaque. So thank you for the question. Martha Reich. Good morning, Dr. Brewer and James West. Good morning to you, Martha. Renee Greenhouse. Good morning. Brothers, low vitamin D linked to COVID. What about thiamine B1 and as a result of a high carbohydrate diet? The B vitamins are very, very important. Yes, and even a lot of the more slower conservative medical groups like Harvard and Mayo and some of the others have acknowledged vitamin D3 is very important to health. And yes, seems to have a significant preventive effect in terms of COVID if you get coronavirus infection. Now, the B vitamins as a group are very much associated with health as well. I mean, if you go back and you look up Z-Dog, Z-Dog MD, he's a guy that got famous making he's a what we call an intensivist. He works all the time in the intensive care unit. And he had a video on MTHFR, poor methylators. And he said, yeah, it's real, but it doesn't matter. Well, you know what? If you're going to be seeing a patient for at most 2 weeks, usually 2 days in an ICU, maybe methylation doesn't really matter that much. But most of us really have a longer term time frame than that. If your time frame is decades, methylation is very, very important. It has to do with oxidation and reduction. In fact, I was talking with James about that this morning. He's going to see if he can get Dr. Craig Brown. I'll not be available next week. I'll be in an airplane. And we're going to see if we can get Dr. Dave Vigorous and Dr. Craig Brown to get together and help talk a little bit about the B vitamins and why they're so important to oxidation. James Canner, my vitamin D3 level is now 81. Good for you. Serum calcium 10.9. Was taking D3 3,500 units, K2 100 micrograms. I passed a kidney stone last month. What should I discuss with my endocrinologist? A lot of this is going to depend on your endocrinologist's knowledge. I know, James, you've attended our channel quite a bit, and you're very much aware of some of the supplements, much more of the lifestyle associated drivers of health. I don't know how much that has how much of that information you've been able to share with your endocrinologist, how much your endocrinologist may already know. But I think just quoting him this information is likely to be very helpful. Eric Jones, how would one know when bisphosphonates are needed? So it's an interesting thing. I've mentioned that James is working on the Medicare Advantage program. There's Medicare Advantage relies very heavily on HEDIS. HEDIS is a set of quality statistics that involves things that doctors tend to miss and things that really make a difference between a good medical system and a poor medical system. Well, one of those things is, have you had a DEXA scan? DEXA bone densitometry. And here are a couple of places where it matters in terms of whether the doctor was doing his or her job. Number one, if they had a DEXA scan prior to this fracture. Number two, if the DEXA scan showed significant problems and were bisphosphonates discussed with patients. Quite often, patients don't get in time, and it doesn't get diagnosed until the fracture already happens. Again, most docs see a fracture in an older person or a middle-aged person. They still don't think about, we need to get a DEXA scan, a bone densitometry. And very few of them talk about lifestyle. And I don't know, when's the last time you saw your doc wear a weight vest into work? So great question. Thank you for asking it. Aura Ruth coming in. Great to hear from you, Aura. I hope you're doing well. Long time no see. Eric Jones, most K2 supplements are in the microgram range. Exactly. Not milligram range. 45 milligrams seems extremely high. Doesn't it? That's exactly, Eric, thank you for repeating that. That was a major part of my point today. For those of us who have been worried about, I get questions all the time, Doc, should I be taking more? You're telling me to take more than this 100 micrograms that I'm seeing in my in my K2 supplement bottle. People are taking it, the same thing, for a different indication, except 150 times the amount. And studies are not showing negative stuff. Now, I will say, pardon me for always going down bunny holes, but that's not entirely the case with every supplement, every over-the-counter thing. A vitamin E, vitamin A, you can get into some challenges. In our space for cardiovascular health, we've mentioned, and especially related to this, we've mentioned vitamin D3 several times. I've had people with come in to see me with too much D3. I know of a couple of patients that have had problems with it. There is a couple of physicians that, well, here's what typically happens. I did a video on this, and the lady did a great video. She told her whole story. She was seeing a doc, and the doc did as docs that are in tune with supplements often do. This doc said, here, let me give you these pills, and they have 25,000 international units of vitamin D3. Now, I don't think the doc meant for the patient to take it every day. I think the doc meant for the patient to take that weekly, but not sure. The patient came to see me. They were taking 25,000 international units a day, and their kidney function was declining. We continued to fight. She came back with a vitamin D3 level of like 125, I think. Again, you can look it up, Ford Brewer overdose vitamin D3. And obviously when we saw that, I called her, told her what was going on. She went off of the vitamin D3. We followed her kidney function over the next couple of months, and it came right back up. And that's what typically happens when you get into these situations. The most common cause of an overdose of vitamin D3 is that kind of situation where people take these weekly doses, except they take them daily. Martha Reich, I take K2 minoquinone 7 from soy. Is this the best, or is there something better? I don't really have a whole lot of opinion and haven't seen a whole lot of evidence out there that there's one type of K2 that's a lot better than another. Great question, though. Thanks. Or Ruth sent an email. I've avoided COVID, but I'm struggling with organ damage from being sick with ordinary viruses. I'm sorry to hear that, Or Ruth. And if you sent the email to me, I didn't see it. Oh, by the way, thank you guys. Along the bottom, you see this this thing. Help get the word out. Like, share, subscribe, and donate. Daniel Trevor, as I discussed a few minutes ago, who's writing that book, said, Doc, you really got to engage people. You've got to give a call to action. And he was right. I'm retired. I've retired a couple of times, and obviously I'm focused on helping people with their health. By far, the most, it's like Janice and I were talking this morning. It's like Jack Kennedy said about ask not what your country can do for you, ask what you can do for your country. And the reality is, when you go into, there's science around this. You're much happier when you're not focused on what's being done for you. You're much happier when you're focused on what you can do for others. And my choices on what I can do for others is to help with this preventive knowledge, help people. Again, the majority of death and disability is entirely preventable. And yet people don't know that. They don't understand it. I don't charge for YouTube videos. They're a free service. One thing I would ask, though, is if you will refer this, if you will if you'll react to it, like, subscribe, and most of all, if you repost these things on social media, and other folks come back in through the social media to see this information. it makes a big, big difference in terms of the AI, the artificial intelligence, the algorithm for YouTube. It realizes that humans are reacting to this life-saving information. It's important, and it'll start putting it out there. So thank you again, guys, for putting that up there. Boder Indre, hello, Dr. Ford. Is it true that if I take 10,000 D3 IU, then I should take 100 micro G2, and if I take 20,000 D, there are a lot of people that would put that together. I have not, at least from my perspective and my review of the science, I have not seen this lockstep ratio of K2 and D3. I've seen people mention it. I've never seen evidence to support it. Aura Ruth, sent to PrevMed heart risk. Oh, this AM. I'm sure that Michelle will see that. Thank you, Aura Ruth. And she will send that over to me. James Cantor, one question I have. Should I decrease my D3 to one? Is that 1,000? The good news from a blood test is A1C remains at 5.4. I can't tell if that's 1,000 or 10,000. I will tell you this, James. In review of the literature, I've never seen anybody get into trouble with D3 at 5,000 international units. People will typically come in to me and they'll say, well, I'm taking it in my multivitamin. I've never seen a generalized multivitamin that has more than 1,000, occasionally 2,000. And usually that's just not enough. The other thing that you tend to see is that, like many things in our body, having a lot of extra fat is a problem. D3 is fat soluble, and fat tends to absorb it. So what I recommend most people do is, number one, go ahead and just start with 5,000, and then number two, go ahead and get a blood level. Now, you said yours was 81. I think 81 is a good number. I don't remember how much you're supplementing right now, but again, 81 is a good number. If you're stable, I would remain stable on that. Robert Thompson, is TRT cardioprotective? Testosterone replacement therapy. One says good, the other says bad. Thanks. You know, when TRT first came out, I was very concerned about it. And it's because when you look at heart attack and stroke risk, men have heart attacks earlier. Because of that, we've come up with a couple of things. You know, logic sometimes works, but sometimes it doesn't. One of the things was that, well, women don't have heart attacks and breast cancer is what really kills women. Wrong. Could not be more wrong. What is it? 30 times the number of heart attack deaths among women than breast cancer. The other thing that happens is this assumption that because men have heart attacks earlier, then testosterone must be causing it, and a lot of fear with that. Actually, there were some definitive studies done. At this point, it was about 3 or 4 years ago, a series of studies, and it made some very, very strong points. One is testosterone. I do not at all think that testosterone causes a problem, increased heart attack risk. On the other hand, I don't think that it does a whole lot of, it's not cardioprotective either. So I don't think it really helps. The major clinical trials for testosterone actually didn't show a whole lot of the erectile dysfunction impact that a lot of guys hoped to see either. But it did show one thing over and over and over and over again, and that was improved sleep from the testosterone clinical trials. But think about it. Sleep is a very, very important determinant of health, both in terms of diabetes, in terms of energy, in terms of mental health, in terms of cardiovascular health. So I don't take TRT. It's a major hassle. I've not been involved with it. I don't give it because testosterone is still a controlled drug in the vast majority of states. And because most of my practice is telemedicine and across state lines, I've just not gone there. I don't want to distract from true prevention of heart attacks, strokes, the major killers, the major disablers. But to go back to your question, Robert, I think the science is becoming pretty clear. It does not cause heart attack and stroke risk. Don Tocho, thank you, John. Don't forget to think about joining Dr. Brewer's Patreon. Thank you very much, John. I do appreciate it. And again, if you can do some likes,